Very good.
Good morning.
Good morning.
Good morning.
Good morning. Made it on time. I will call this Board of Health meeting to order this morning. It is October 28th and we are the so welcome. Yours.
I apologize for that. That's what happens when you're running late. You've got so much going on this morning that, but I got it done. I met the deadline for 9:30. So now we'll go on to the call of the public. Is there anyone here that wishes to speak? Seeing none, we'll close the call of the public and go right into our presentations. The first one is a presentation from the Public Health Opiate Settlement Grant recipients.
Excuse me, Chairman. Should we make sure we have quorum first?
We do have a quorum.
Okay, thank you.
So we have the Mojave Substance Abuse Treatment and Education Prevention Partnership by Bob DeVries. Good morning, Robert.
Good morning, Madam Chair, members of the board. Happy to be here today and talk to you about one of our programs that I'm very proud of. And that's our Quality of Life Court program. It's an early intervention program. We started a pilot program with this some time ago, and it began with conversations between with us, along with Judge Horta and Judge Taylor at that time, in regards to what we could do to possibly intervene earlier with individuals that are suffering from substance use or opioid use disorder. I'm sure most of you are familiar with drug courts, and drug courts are a great program. They have a great benefit, but many times individuals are very well seasoned into their disorder by that time, and it's very difficult for them to transform and change their life. So we wanted to try and catch it at the early stages. Much like, if you would, looking at it as cancer. You know, if you're diagnosed with cancer, you don't wait till they're stage 4 to begin the treatment. You want to catch it early and try to make a difference. So we launched a program. Whoops. We set up some criteria at that time. We're trying to look at using first-time or low-level offenders that would come through the Kingman-Surbat Justice Court. And it came at the recommendation of the judges, the prosecutors, the defense attorneys, and at times law enforcement. And many times right now we're actually seeing law enforcement refer individuals to the program at the time of the arrest, telling them this is a program that I believe will benefit you. We've actually changed that criteria somewhat now, where we will take individuals that aren't necessarily within that criteria, but we believe would benefit from the program. We've actually have individuals that have specifically requested the program based upon the success and the things that they're hearing on the street. So we began to, like I say, address the OUD and SUD at the earliest opportunities. And how we began with our pilots, we learned where it was working, what we had to change, and where we could get the best results from it. It involves intensive probation and counseling as well as group sessions the individuals participate in. But really the secret sauce to it is the strong peer support. There's individuals that have walked in that life and are now actively working to help individuals through the disorder and moving forward in their life. And we've had tremendous success. To date, we've had 35 graduates. And what we're extremely proud of is of those 35, we have 0 recidivism rates. Some have had some moments of relapse and have been actually assisted with those peer support as well as their other members that are participating in the court. That was something we never really planned on or thought to look at, but they've actually developed their own strong support system internally with that. 8 of our graduates are now working as certified peer support specialists in the region here, helping those with disorders. And they've developed their own special support networks. Like I say, they have a phone tree. They're out working with each other. If anybody's struggling, anybody has a need, they call upon their peers and they come out to assist tremendously. And proud to say that with the 35 graduates, we're going to have 2 more added to that list on December the 9th, which will continue to help the program. They've also started to initiate their own community work service projects. They were out in force at the Walk Away from Drugs just a week and a half ago. They've been out doing cleanup projects, and they're out assisting with like horse rescue, dog rescue operations, anywhere where they feel they can provide back to the community with their success. The other thing that we've done for the last 4 years, our speakers at the Walk Away from Drug have been graduates of the program. They have the opportunity to get up there and tell their life story, hopefully impacting individuals that have attended at the walk Away from Drugs. We've had individuals that have come up to us. One of them that attended one of the very first walks came back and indicated, "You don't know me, but I was here for that very first walk." And said, "I didn't come for help. I came because you were giving away food and I was hungry." But they learned as to what services were available, and they were able to move forward and into a life of recovery. We did something very special last month. One of the things we've really wanted to do for a long time and didn't really have the opportunity to do it was to celebrate all of our graduates. September 7th was our very first Quality of Life Court graduation, our reunion. And we held that in one of the local city parks here. The judges and I did the cooking and did the serving, and we had over 40 of our graduates and their family members come out to celebrate a continued life of recovery. So those are successes that we continue to see and record all of the time. And with that, I know it's a brief presentation, but I'd be happy to answer any questions that you might have.
Okay, thank you. It's a great presentation. Appreciate it. Does any board members have any questions or comments? Any board members on the phone? Looks like you're off the hook there, Mr. DeVries.
Feel free to contact me at any time through MSTEP if you have any questions or if you know an individual that could possibly benefit from the program. So, thank you.
Certainly. And then did we have Tina Sweeney that wants to present as well? I didn't say your last name because I didn't want to mess it up.
That's okay, it's a mouthful. All right, first of all, I just want to say thank you for having me here. It's so nice to see some of your faces, to put the faces to names. And also,
Can
I
you
do
pull
want
the
to...
microphone down a little bit? There.
Is that better?
Perfect.
All right. Thank you so much for having me. And I also want to state that Bob DeVries, who just went before us, he was instrumental in our court also launching the same program. We were there, the Kingman Justice Court was a mentor for us under the MSTEP grant previously, and so that's how we started on this process as well. So great accomplishment to you, Bob. I love the success, and we're hoping to have the same. So the Lake Havasu Justice Court launched the Quality of Life Drug Treatment Court about 1.5 years ago. about us. Our court, this drug court, is designed to address substance abuse and addiction issues. Our mission statement as a drug treatment court is to help restore individuals back to a place of dignity, to their families, their community, and more importantly, themselves. Obviously, we have an opioid crisis. According to the Health Resource and Service Administration website, in 2023, more than 130 people a day die from opioid-related drug overdoses. Prevention and access to treatment for drug addiction are critical for fighting this epidemic. And we got some stats from the Drug Enforcement Administration, and these are fentanyl facts from 2024. There were 37,700,000 millions of fentanyl pills seized in the United States. 5,444 pounds of fentanyl powder was seized. 7 out of the 10 pills seized contained a lethal dose of fentanyl. And sadly, we all know that one pill can kill. The opioid epidemic is present in Mojave County. At the Lake Havasu Justice Court alone, we have individuals arrested on narcotic drug offenses on a regular basis. In 2024, we've had 129 drug charges filed thus far, and this is only October. Fentanyl possession and use are definitely on the rise in Mojave County. It used to be heroin seemed to be the big drug that was a problem, and certainly fentanyl is something we see on a regular basis. What do? Well, we have the ability to have direct contact with people that are struggling from addiction when they're arrested for drug possession. And this is where the opioid settlement funds can directly help change the trajectory of an individual struggling with addiction. And just like Bob stated, our courts, the justice courts, we see felony offenders at their initial appearance. So if someone's arrested for the very first time of having fentanyl possession or any drugs for that matter, they have first contact with the justice courts. If the case is severe enough, it'll be sent to Superior Court where they would be indicted up for potential drug sales, things like that. But generally those first-time drug offenders stay in our court and are offered a misdemeanor drug plea, which we'll talk about in a minute. But like Bob stated, if they're in the cycle several times, they tend to be in the Superior Court path, which at that point, sometimes it's difficult to reach them. Without a drug treatment court, a first-time offense for drug possession typically results in the following cycle: a plea agreement with a fine amount, unsupervised probation, jail time, drug counseling, and drug testing. If they do not comply, which is not uncommon, unfortunately, they're issued a failed to comply warrant, and then they start the cycle all over again, using a lot of resources that just continue the process. Some of them follow this cycle for years and years without achieving any real success. How does a quality of life court differ? In the quality of life court, individuals are offered a diversion opportunity by agreeing to the terms of our program in exchange for having all their charges dismissed at the end of the program. It can take up to 18 months to complete the program, and this also helps to preserve their employability later if they do have charges dismissed. So it's a wonderful opportunity for them to really start fresh. Some additional benefits of the quality of life court include the following. We have a team of individuals made up of the court, probation, drug treatment providers, Department of Health officials, drug testing agencies, and other stakeholders to create accountability and camaraderie for our participants. We also include supervised probation, drug testing in the form of UA testing or drug patch, peer mentor support, incentives for their sobriety. These additions allow for more individualized accountability and support systems for defendants with addiction. It gives them a better chance of not becoming repeat offenders. Some of the opioid settlement funds are also used for training for the team members to provide our court access to the latest information in the fight against drugs, rewards for our participants as they achieve milestones in the program. We just recently had someone celebrate 1 year sobriety, which is a huge deal. So we had cake and their family members come, and it was very amazing to see just the progress that happened. Additionally, the monies are used to pay for drug testing, and that's a huge benefit to participants. It's a good motivator to get them to want to be in our program, because if they could take a plea agreement and pay their $500 fine and be on their way, or agree to commit to a year-long program, it takes a lot of motivation to get someone to want to do that, and providing free UA testing is one way to do that. Are drug courts effective? According to a 2024 study published by the National Library of Medicine, a study shows that a Swedish version of the drug court, which does use the contract treatment sanction, which is what we use in Kingman and in Lake Havasu, it reduces criminality and substance abuse related health harms. Importantly, it is more effective than imprisonment and probation without a treatment component. Drug courts reduce use and rearrest for nonviolent drug-involved offenders. And we've already seen massive success. We are a very small program because we just started, but currently we have 3 individuals in our program who are thriving and on track to graduate this year. And when this PowerPoint was created, it was before our graduation, which we just had on October 23rd. And so we proudly have 2 graduates who just completed the program. One participant was resistant to the idea of inpatient treatment program. He was unsuccessful in the program until he was finally convinced it was necessary for his full recovery. The alternative was that he would be released from our drug court and more likely continue on his path of drug addiction. He had a family and a newborn baby, and the impact of his sobriety has made on his family is priceless. He's a new man and a role model for other participants. And he's our proud spokesperson as well. He tells everyone he was the first one. We had another participant who found 1 year of sobriety and healed relationships with her adult children. She's also been a rock of support to the other participants. And like Bob mentioned also, they do create this camaraderie out of this program, and they do support one another, and that's really beautiful to watch. This particular person, her adult daughter, came and spoke at our graduation, and that was very meaningful. Another participant also celebrated 1 year sobriety, and his significant other is now in inpatient treatment. His whole life has been impacted by the accountability provided by our program, and his girlfriend has been sober for 60 days now. The setback. So while supporting our participants in their journey, a prior grant that we were operating under expired in the fall of '23. We lost our ability to provide a crucial part of our program, probation, peer support, and drug testing, and that's what the opioid settlement monies goes towards. We were unable to add any more participants, and we were desperate to find funding to continue to grow our new program. In the fall of '24, we received news we were awarded opioid settlement funds, and that's what our faces looked like in that moment. It was a huge accomplishment because we realized we weren't going to have the component of probation to help us without the funding, and they really provide a great deal of accountability to our participants. Additionally, we had the people that were in the program, they had to start paying for their own drug testing, which, was challenging in the midst of being used to not having to do that for a majority of the time. The path forward. Thanks to the opioid settlement funds, we have now begun screening and admitting individuals back into our program again. Please join us for our formal graduation, which is past, but this was from a month ago. And just to mention, quickly, we have a new participant that was just entered an agreement to be in our program. She's 20 years old. Her baby is in Department of Children's Services care right now, and she is a fentanyl user. And so the impact that we can have on our community is great. So thank you for giving me the opportunity to speak. And do you have any questions?
Okay, thank you very much, Tina. It was a great presentation, and small is always a good way to start. So do I have
Madam
someone
Chair?
on the phone? Yes, go ahead.
Yes, this is Terry Coyle. Miss Tina,
Yes.
how many can be in the program at one given time?
Well, currently, we have set a max of 20 participants because we are new and we do have growing pains, and I am limited in the staff that I can provide as well. So at this time, there's a cap of 20.
Thank you. And I just have two more questions.
Go ahead.
Once in the system, how long does it take the individual to get into your program?
Probably less than a couple weeks. It's essentially when they get arrested, the county attorney, and this is true for all cases, the county attorney determines if they're going to offer them a plea agreement. And so if they're eligible, and eligibility is screened by the county attorney's office, if they are eligible, then they're offered 2 plea agreements, one for the drug treatment program and one with the traditional path. But the timeline of getting into the program is not any longer than it would be for them to accept a plea. So on felonies, they're usually resolved within, I would say, 3 weeks tops.
Okay. And my last question, I know this might be difficult to answer. Try to give your best estimate. Cost per successful individual in your program.
Repeat it. Sorry, you cut out a little bit.
What's the average cost per individual, assuming that it's successful graduation?
That's a great question. Our drug tests are about $11 per person. They test 5 to 10 times per month, sometimes more. The probation cost per participant is difficult it's hard to quantify, honestly, but I can give you a breakdown after this meeting of the exact amounts, but I can tell you the cost not to do the program is far greater when you consider someone doing jail time and also repeating the offense when it takes staff to issue warrants. And then law enforcement, of course, has to go out, arrest these individuals, which puts a burden on our jails. And they just keep repeating the cycle. They're not paying their court fines. Their cases go into collections. So I don't have an exact amount for you, but I can say it's far less than what we're currently paying.
I thank you and Bob and Miss Tina as well for providing an avenue, knowing that the old system is broke, and this allows an opportunity for fallen adults to try to pick up and start over. Thank you.
Thank you, and thank you all for your time.
Any other
Thank you.
questions?
I have a quick question. In terms of the support for your program in the acute phase of withdrawal, you mentioned inpatient. Do you have enough support for those individuals or program to let them know that there's a system to help them with this initial withdrawal symptom?
We work closely with the counseling agencies that, if necessary, community medical services is part of our staffing team. So yes, if we have a team that can source out any kind of, because I know to get into inpatient treatment, sometimes you have to go through a detox. So depending on the situation, yeah, we absolutely have those options available. We had one participant who did treatment, but he was a meth user and he had been sober for a short period of time, but he didn't require that, but yes, absolutely, we have that ability as well to provide for detox.
Right. Yeah, I mostly work inpatient, and that is a component that we need to offer,
Mm-hmm.
so the individual don't have the fear that they don't have that support.
Yeah, absolutely.
My hospital in the county should be able to support those patients, and again, after we clear a patient, then they can go to inpatient safely.
Yeah, absolutely, absolutely.
Anyone else? Thank you very much.
All right, thank you.
So next, we have Hunter Adams with Creek Valley. Hunter, are you on the line?
Hi, everyone. Yes, I am online, and I am getting some sound feedback in the
Okay.
that be resolved. But yes, I am here with Creek Valley Health Clinic to present on our programs. Funds. I was told maybe that someone's there. Thanks for me.
Okay, we can see you now. The audio was a little bit broken, so hopefully that clears up as you present.
Okay, great. Well, please, interrupt me if there are any sound issues.
Okay.
All right. Hopefully, you can all see my screen here.
Yes, we can.
Okay, next slide. So before going into the depths of, I'm so sorry, could you mute in person? There's just an echo after I talk.
It sounds okay on our end.
Okay, well, maybe I'll turn off my sound. It doesn't feel like I'm talking to myself.
I'm sure that's frustrating.
Okay, so once again, yes, I am the CEO of Creek Valley Health Clinic. I just first wanted to say thank you so much to the county. We were one of the organizations awarded for the fiscal year 2025 opioid settlement grant. And so, yeah, first off, I just wanted to say thank you. This will make such a big difference in our community and the people that we serve. At the time of our application, we had a team of 4. We had 2 behavioral therapists, a director of our program, and a case manager. We provided limited substance use services, counseling, and MAT services. If we rewind a little bit, I just thought it'd be helpful to give a little bit of an overview of who Creek Valley is and who we serve. We were established back in 2018, and we became a federally qualified health center in September of 2019. We saw our first patient in December of 2019, so we're coming up on our 5-year anniversary, right before the COVID pandemic came. So we provide what's called integrated care. So we provide both medical, behavioral health, and dental services to about 3,500 patients per year, most of which reside in Colorado City and the surrounding area. We're about 4 hours drive time north of Kingman, so it makes it difficult to come to these meetings, but I try to make it whenever I possibly can. Beyond what we call our direct services, we also provide supporting and enabling services such as case management, patient navigation. We can support individuals as they apply for Medicaid, referral management, community health education, and other support services to try to provide as much as we possibly can for the residents of Colorado City. Next slide. I know sometimes pictures can speak louder than words, so I wanted to give just a quick virtual tour of Creek Valley. I know many of you may have never been to Colorado City or driven through on the way to maybe Zion National Park. On the bottom right there, that is about 5 minutes away from our clinic. You can see the Red Rock Mountains, and then right on the other side of that is Zion National Park, just to give you some bearings on where we are. At the top left, that is the entrance to the medical side of our facility. We have a separate entrance for dental, and then behavioral health is integrated, and it's all under the same roof. Our average family size up here in Colorado City is about 8 people per family. So we have 2 rooms, 2 pretty large rooms specific for pediatric care. You can see those right there. We have our fire truck room and our elephant room. Our waiting room is in the bottom left, and then the quote in the middle there is hanging at our staff break room. Next slide. We just recently finished an expansion of our clinic facility, and that included a conference room, which you can see on the top left, where we do quite a bit of community health trainings and activities. So we do mental health first aid for the community, trauma-informed care, and then some internal staff meetings on alcohol use disorder, opioid use disorder, and many other trainings that are relevant to the opioid settlement program. We have, in our expansion, we have 3 rooms that are specifically created for behavioral health. You see off to the right there, that's one of them and what they look like, and to support the growth of our behavioral health team. The bottom of which we just recently started dentistry services, so we can provide panoramic dental x-rays at the bottom right there. And then just to give you an idea of kind of what the operatories look like, you see the Red Rock Canyons in the bottom left picture there. We designed the dental operatory to try to reduce as much dental anxiety as possible. So next slide, please. So now a little bit more in depth on our behavioral health program and what we're hoping to do with the opioid settlement grant. All the program efforts roll up under Matt Laszlo. He's our Director of Behavioral Health Services. Prior to working at Creek Valley Health Clinic, he worked in Page as a crisis counselor and a behavioral therapist for about 12 years. Since the time of our application, our behavioral health team has nearly doubled. We've grown by 3.2 FTE, including a part-time clinical psychologist that can diagnose for mental health disorders, and she has demonstrated experience. She's been working with the community for upwards of about 25 years now with patients with severe mental illness, substance use disorder, autism, and so many more kind of prevalent mental health components in our community. To give you some baseline of where we're at and where we're going, in 2023, there were 875 patients that received counseling and/or integrated behavioral therapy at Creek Valley Health Clinic, and about 80 received substance use disorder services. Through our activities of the grant, we're hoping to grow both of those numbers by between 5 and 15% in the next 3 years. And the services that are supported specific by this program include the screening, treatment, education, counseling, and connection to care, whether it be IOP programs, inpatient programs, or others, for patients with substance use disorder, opioid use disorder, alcohol use disorder, and mental health needs. Next slide. One thing I wanted to mention, early last year in 2023, we implemented what's called the collaborative care model. This has been a really powerful model that was born out of the University of Washington that aims to connect primary care services with psychiatric consultation and psychiatric services. So this model kind of runs side by side with our behavioral health program, but I just wanted to put this slide there in case you know of any other agencies that are interested in kind of better serving their patients with severe mental illness or substance use disorder. It really gives access to psychiatric information and psychiatric education for our primary care docs, our behavioral health therapists, but most specifically for the case managers that work closely with these patients as they're going through recovery, treatment, and medication adherence. There's a link at the bottom there, and hopefully these slides are available. If you know of any other primary care agencies that are really interested in, maybe we don't have a budget for a full-time psychiatrist, but we really need some psychiatric care or psychiatric information, this has been an amazing model that we implemented last year. Next slide. So the next 2 slides are a little bit kind of in the weeds, and I apologize for that, but I just wanted to give the board a little bit of some information on what we're accomplishing, what activities and what timelines and what we're reporting on for the opioid settlement grant itself. So first off, it's going to support the improvement and advancement of our direct patient care, the delivery of therapy and integrated behavioral health. It will support referrals to outside treatment. As I mentioned in the collaborative care model, it will support our psychiatric services, consultations, and direct patient services for psychiatry. It will provide some support for school visits, increase access to Vivitrol, which is a medication with great outcomes for alcohol and opioid use disorder. It will also allow us to implement some other medications, such as Suboxone, to help support patients in need. An implementation of the SBIRT process. SBIRT, for those that may not know, is screening, brief intervention, and referral to treatment. It will support a community-based trauma-informed training and other community education events and outreach. And then it will also support some very specific continued medical education and staff training for alcohol and opioid use disorder and how to support those patients in need of that service. Next slide. So really quick on a high level, what success means for our program is really what are the number of people that are supported, what are the number of visits that we're completing, and then how are we as an agency able to improve and advance our trainings, our processes, and our delivery of service to really provide the best care possible and try to reduce substance use and support the entire system. You know, as in the previous presentation, we are going through an opioid epidemic. So what can we do in our small slice of Mojave County to really support those with the most need? And then in addition, just on the community-wide scale, can we distribute naloxone and Narcan and teach signs of overdose so that we can get the resources in the hands of community members to really prevent overdose deaths and prevent substance use. That is all. It was pretty quick conversation. I just wanted to open up if you go to the next slide, if there are any questions about Creek Valley specifically, or what it means to be a federally qualified health center, or anything specific to our behavioral health program, I'm happy to take a couple of questions if there are any.
Okay, thank you very much.
And let me turn on my sound here. So sorry about that.
Actually, the sound was good, and your presentation was excellent. Your clinic is as beautiful as your Red Rocks. So I'll open it up to any questions or comments from the board.
This is Bob Litz. Can you hear me?
Yes.
Hello, Robert. Good morning. We can
Hello,
hear
good
you,
morning
and you
to
have
you
the
all.
floor.
Oh, okay, very good. I seem to be suffering from a reverb effect from the two microphones being too close together or something like that. And it's very difficult for me to hear what's being said. I don't know if anybody else has got that trouble. This is a thing that is very near and dear to me. I cleaned up in 1991. And so these personal success stories are very important to me, and I think they work. I also believe in the value of peer groups working with others on this situation. So I'm glad to hear this here. I also am a mentor for Veterans Court, and a lot of the addictions, have caused people to wind up in Veterans Court, in particular alcohol. And I'm glad to see this program. I was unaware of it until now. And I was wondering if perhaps we could get somebody from the IT department down to work through this reverb effect, this echo in the thing. And I don't know if it's hitting everybody, but it's certainly getting me.
Okay, IT, I don't know if you were able to hear what he was saying, but apparently he's unable to comprehend a lot of the presentations. If there's any tweaking you can do with the sound, we would appreciate it. Okay, thank you, and thank you for the story of your success. I appreciate that. Any other board members? Okay, then we have a presentation from Teros. Sorry about the stairs. I always feel like I'm dragging my leg when I walk down those stairs. It's very unnatural.
Same, and age doesn't help that at all.
Yes.
Good morning. I'm Melissa Register. I'm the Crisis Clinical Manager with Teros Health here in Mojave County. A little bit about Teros Health. Teros Health was the first provider of mobile health services, crisis services in the state of Arizona back in the late 60s. Since then, the last 55 years, Teros Health has grown into a truly integrated healthcare system, most specifically in Maricopa County. However, clients that we engage here have opportunity to receive the benefit from those services as well. So integrated care would be mental health care, physical, medical care. We have a number of inpatient programs. And actually, Teros Health just recently merged with LifeWell in Maricopa County as well. And they also have some housing with mental health components associated. Here in Mojave County, we currently are providing mobile health services, mobile crisis health services. Our hope is, and actually the program I'm going to present to you today is allowing us to provide some clinical level services, and we are working on establishing additional clinical services in the very near future. The opioid settlement grant has allowed us to create a program called Crisis to Recovery. Crisis to Recovery, or we often refer to it as C2R because it's a fun little way to abbreviate all of that. So mobile crisis services are considered a first responder program. The idea being that we're mitigating interactions for clients who are experiencing crisis of any sort. It could be mental health or otherwise. And currently, mobile crisis here for Taros serves the Kingman communities as well as the Bullhead City communities, which is a lot of communities. So we're currently running over 300 calls a month, clients that we're engaging and trying to help mitigate those crises, whatever they may be. Of those 300 calls, I would offer that 2/3 of them are probably somehow substance related in some way. And the idea or concept of Crisis to Recovery is the extent of the services we can provide through crisis funding is up to 14 days. That's typically not enough time to get someone engaged in long-term care to address their needs. So Crisis to Recovery is a referral system from any of my staff who engage people in crisis, but also a number of stakeholders in the community that we've made connections with and trying to collaborate to make sure that we can help get these people into and address their needs, whatever those may be, but specifically if we can help them address the substance abuse portions. So we're not actually providing that substance abuse care for them, but trying to help connect them to that care. Sometimes that might be that they don't have housing. Somebody who doesn't have housing has a very difficult time engaging substance abuse treatment. It may be that they need detox, as was mentioned earlier today. It may be that they need residential care. Perhaps they need some sort of, I apologize, my mouth is getting really dry, but it may be that they need some sort of lower level care that might not be residential, but still has some accountability, like some of our local programs like Angel Manor, some of the other, I think it's ECRC is another agency that provides housing and some assistance with care. It could be that they lack transportation to be able to get to these appointments, et cetera. My staff for Crisis to Recovery are able to help assist in those respects. So we are currently engaged with a number of community stakeholders. Some of the recovery courts we engage with. We've interacted with probation. We've received referrals from local hospitals and medical providers. We have also received referrals from the hospitals in the Bullhead City area as well. We've received referrals from APS, from DCS, from DES. So we've gotten referrals, over 250 referrals since we started the program. We were actually, thank you very much, appreciate that. We were actually a benefactor of the first series of opioid settlement funds, and so we've actually been providing these services now for well over a year. Thank you so much, I appreciate that. So currently I have 2 staff that provide case management. They're doing some skills training with some of the clients. They are offering peer support to many of these individuals. Just the simplest things like helping somebody obtain their driver's license. so that they can obtain other services. Both of my staff are now able to enroll people for access if they qualify, which is often a huge barrier. A number of the individuals we're engaging with may come from the jail where they literally have nothing at the time of their release, and my staff are able to offer them a warm hand to help them get to the next thing that they need in order to be successful and hopefully engage longer-term care. Some of the success stories that we've encountered so far include helping some elderly individuals get into longer-term housing where they have some access to assisted living as well. We have provided access to a number of folks to be able to go to long-term substance abuse treatment. We can make those referrals ourselves as an agency now. We have engaged a number of people in recovery communities here in the Kingman area, but also in the Bullhead City area. A great example is we had an individual in Bullhead who had experienced a crisis. He was on felony probation. He lost his housing. We were able to help connect him with some housing stability. He has now obtained employment and is back on his way to being self-sufficient. The ultimate goal of a second responder program like Crisis to Recovery is to help mitigate these individuals from returning to other crisis, which is oftentimes involves law enforcement or the hospital care system, which are very costly systems that if we can help keep individuals out of those services, then ultimately we save the community a significant amount of time, effort, and money. Any questions about Crisis to Recovery?
Any questions for the presenter?
I apologize that I didn't bring a slide presentation with me. I just didn't even think about it, so.
That's okay. You gave an excellent verbal presentation, and we appreciate it.
Thank you.
It's a good
Appreciate-
organization. We appreciate it.
Thank you.
I would just like to jump in and say this is the first of several grant recipients for the opioid settlement dollars that we will be bringing to the Board of Health. We broke it up into chunks because we did have, I believe it's 12 recipients this year. And so we figured 12 presentations would be a bit much. So there will be more to come at the January meeting.
That's great. I look forward to seeing all of the opiate grant recipients and seeing what they've done with the monies that we've been able to provide them thanks to this settlement. So thank you very much. Our next presentation is the Mojave County Department of Public Health State Opiate Response Overdose Annual Review by Selena. Sure. Okay. Thank you.
Good morning, Madam Chair, members of the board. Thank you for having us today. So I'm going to give you a brief overview of the overdose fatality review process and the findings from our most recent completed year, which is 2022. So the mission of the Mojave County Overdose Fatality Review Team is to conduct case reviews and gather data to report key trends found in local drug overdose fatalities. Our methodology, we received a list of 68 decedents from the Arizona Department of Health Services, and we were able to review in depth 28 of the total. So our sample size is 28 for the review year of 2022. We do have some exclusions because there are separate review teams for these categories. So children are excluded from my list. Death by suicide are excluded, and mothers who have given birth within a year are excluded. Those are all covered by separate review teams. So my process is once I select the sample size, I request records from several different facilities. We request from emergency rooms, crisis teams, medical examiner's office, law enforcement, primary care, specialty care. We're trying to do is analyze the deaths for contributing factors. So we have to try to get a big picture of this person's life and overall health care. Once we review the records, the case narrative is created, and those narratives are compiled into a packet and reviewed with our team. So for the 2022 year, our timeline, we received the list from Arizona Department of Health Services in June. We selected the sample size as soon as we got the list. We collected the records between June and August. Between August and October, we began compiling the case narratives. October was our first meeting. We reviewed 10 at that meeting. December was our second meeting. January was our third meeting, and our final meeting was February of this year. So the process is a little bit lengthy, but to be able to completely get a big picture of what we're looking at, we do need to take our time in reviewing the records and collecting the records. So the OFR team, right now we have a team of 20. Actually, now I believe it's 25. Our numbers have gone up a little bit since this was created. But our team members represent law enforcement, emergency medical services, hospitals, public health officials, behavioral health, crisis intervention, and then we also have prevention groups on our team. And we currently have representatives from Kingman, Bullhead City, and Lake Havasu City. And I am working on recruiting members from the Colorado City area and from the Wallapai tribe or Peach Springs area. So our demographics and findings, I'm going to move into the actual data now. For the 2022 review, more than half of the sample size were female, so it was about 54%. Most of the decedents were in the 35 to 44 age range, and 82% were white or non-Hispanic. From the, I know it's kind of small, but the race ethnicity, our second largest demographic was American Indian and Alaska Native at 11%. And then the third largest was Hispanic or Latino at 7%. Education and employment. The majority actually had a high school diploma or GED certificate. It was 39%. And 68% were employed either part-time or full-time, compared to the 32% who were unemployed. The location, witnesses, and naloxone. So our findings showed that the majority were in their own home when they were, when the injury happened, when the overdose happened. So they were either in the home with a person nearby or alone. 5 of the cases that we reviewed were at another residential address, so maybe a friend's house or a family member's house, and then 3 were outdoors, and 3 were in a non-residential address, which might include a store, a vehicle, something just that's not a residential place. Now, these next 2 are actually very important to me because this shows that 64% had somebody nearby. So that means that someone was with them in the house or in the vicinity of where they were when the injury happened. And then figure 8 shows that 64% were deceased upon arrival. So when they were found, they were beyond resuscitative measures. Only 25% were given naloxone. It's my belief that if more people had naloxone, more of these individuals could have been resuscitated. And we also evaluate co-occurring disorders and other drugs contributing to the death. In 75% of the cases, opioid and psychostimulant, most commonly methamphetamine, were the cause of the death. And we actually found that fentanyl, I think this is a trend that everybody knows, fentanyl is the most commonly occurring in overdose deaths, now more than heroin and other opioids. The next highest was 46% amphetamines and 29% alcohol. For the mental health conditions, we had most commonly occurring were depression at 63% and anxiety at 50%. So that means that 60% of our decedents in the sample size also suffered from anxiety and depression. A total of 75 suffered from any mental health condition. Present of chronic health conditions, so this would be any medical health condition. The most common we found was 36% had hypertension, and then 29% also had asthma or COPD, and 29% also had chronic pain. Other contributing factors and commonalities that we look at: history of suicidal ideation or history of suicide attempts, 32 for the first and 27 for the second. History of self-directed violence, 18%. Behavioral health signs or symptoms in the past 30 days, 29%. Had a behavioral health diagnosis within the past year, 64%. Recent incarceration in the past year, 18%. Any history of incarceration at any point in their life, 36%, and 18% were homeless or had inadequate housing. ACE risk factors we also look into. We can't always retrieve this information on all of our cases simply because we don't have the data available, but our ACEs are the adverse childhood experiences. We were able to collect data for 19 out of the 28. So from those 19 cases, the two highest risk factors for ACEs were substance abuse within the household. So that means when they were children, somebody in their home was using substances, and that's 43% of cases. And then 32% of cases experienced physical abuse as a child. So moving on now to our recommendations. The point of the overdose fatality review is to try to make recommendations where we can mitigate these overdoses. The top 5, the first 3 come from our healthcare section. Increased patient-specific education of overdose risk associated with age, comorbid conditions, prescription medications, and the use of other substances. Establish protocols for emergency department and inpatient hospital discharge instructions to include naloxone distribution, connection to peer recovery specialists, case management, and treatment services. Improve access to primary care services that include substance use disorder screening, harm reduction, education, medication-assisted treatment, and referral to treatment. And then the last 2 come from our community and public health section. And this is increase education and awareness of overdose prevention and harm reduction strategies. For example, naloxone, fentanyl test strips, HIV and Hep C testing. And the final one is improve support for families who have a loved one with substance use disorder. So that could be community events, connection to supports or support groups, or written materials. Okay, and that concludes our findings for the 2022 year.
Okay, thank you very much. Very interesting.
Thank you.
Any questions or comments from board members?
Terry Coyle has a question.
Mr. Coyle, go ahead.
Thank you, Ms. Salino. Great information. This question is in regards to obviously being HIPAA compliant. Is there a voluntary watch list that we can try to address that 64% of those that have committed either suicide or overdose were newly diagnosed within the first year? For 64% to be that high, my assumption would be if we can have some kind of like a watchdog list, essentially, that can prevent a lot of that.
To my knowledge, there is no list. However, we have the option to add in additional recommendations, so I can make a note of that for our next review. We are currently in the 2023 review year, so I think that's a great idea to have like you said, a watch list for people who might have a history of suicidal ideation or history of overdose. The only thing we have currently available is our OD mapping, but it only tracks overdoses. And right now we currently have it set up in, I believe, all 3 cities in Kingman, Lake Havasu, and in Bullhead City. But that doesn't necessarily track suicidal ideation.
All right, thank you.
Thank you.
Anyone else?
Yes, I have a question. Sorry, I have a really bad spasm. But is there any data available on homes with a known substance use disorder who had the naloxone available? Like the families that had the overdoses, how many of those families maybe had the naloxone available, or if we have any available data on that?
And not to my knowledge. The only time I would know if they had it available is after I get the MA report and the death investigation. So when I get my list from ADHS, it's very vague, or not vague, but it's just very general information. So the, demographic information, the cause of death, and the manner of death.
Thank you very much.
Thank you.
Okay, next on our agenda, we have the after action report for Soylent Green and Arizona Health Alert Network by Scott Wright. Scott is the public coordinator for the public health emergency preparedness.
Good morning, everybody.
Hi, Scott.
Let's see here.
Great movie, by the way.
Good morning. Thanks for giving me the time to go over this. Like was indicated, we're going to talk about Operation Soylent Green. It's a tabletop exercise that we held back in July, and after that, we're going to talk about the Arizona HAN Network. Once again, my name is Scott Wright, and I'm the FEP coordinator for public health. Before I go into the presentation, I just want to give some shout outs to people that were part of this team. To put a tabletop exercise together, it takes a lot of work and time, and I just want to shout out their names. Robert Scott and Brian Scott, they work with me. Mike Brown, he's with the emergency management, along with Jasmine Tarkowski and Lauren Wellborn, and then all of them are with emergency management, and then Daniel Lagana. She's our PIO, and she's works with public health as well. Special thanks, and you'll see why in a few minutes, to our IT division, Nathan McDaniels, Jeremy Willestein, and Scott Standen, and also Roger Galloway, our PIO for the county. What basically is Operation Soylent Green is it's a tabletop exercise, and what we're trying to do is determine how well our new plans that we put into effect last year, our fatality management plan and our family assistance center plan, how well that they were going to work in a real world situation. Stakeholders that were involved with these plans came together, and we simulated a mass casualty event. We had representations from local law enforcement, fire, emergency medical services, COADs and VOADs, and medical examiner's office, as well as some of our tribal partners, community services, and public health. Unfortunately, the hospitals were not able to attend. They were invited, but due to conflicts, they weren't able to provide their perspective on the plans. This is just a list of the groups of folks that were there. Arizona DEMA, which is emergency management for the state, they were there. The Kaibat Band of the Paiute Indians and Fort Mojave were represented at the tabletop exercise. Of course, public health, risk and emergency management, community services from Mojave County's AMR, Havasu Police Department, Mojave County Sheriff's Office, Mojave County IT, Bullhead City School District, their PIO was there. Mojave County Medical Examiner's Office was representative. The Lake Havasu City PIO was there. Lake Havasu City Fire Department and La Paz County Health Department was there. The COADs, which are basically community organizations that are assist in disasters that were there, was American Red Cross, the Salvation Army, United Way, Teros, River Fund, Cherished Families, and Mojave County Medical Reserve Corps.
Wow.
The scenario that we talked about was July 19th, 2024. Mojave County is hosting a 3-day county fair. And just so one of the things that we did is we didn't say it was in Kingman or Bullhead or Havasu. We just created a new city in Mojave County, and we called it Mojave City. Attendance that were going to be at this event was upwards of 6,200 people in a single day. This year at the fair, we were hosting several local bands, carnival rides, food trucks, and other multiple vendors, 4-H, native cultural arts exhibits that were going to be located in the main exhibit hall. The state senator was going to be present giving a speech, and on Saturday, July 20th, shortly after the afternoon, a vehicle crashed into the crowd, a crowded main hall, causing an explosion and fire, which resulted in the mass casualty fatality incident. So that kind of just sets up what our scenario was about. And this is what IT and Roger no, I take that back. What is Soleil Green? See if we can get this to work. This is Roger Galloway.
Wow, it's been a harrowing day for residents and first responders of Mojave City. I'm Roger Galloway, KNRP News 10, and we're following today's top story, the Community Event Center explosion. Now, so far, we've received reports of at least 10 fatalities and an unknown number of life-threatening injuries found at the scene of this incident. So far, initial missing persons reports are coming in upwards of 100. The reception area is overwhelmed, by the way. Outside news outlets are crowding the scene. Authorities are right now in the process of opening a family assistance center. That happens soon, hopefully. We'll keep you posted on its opening. The explosion allegedly occurred from a single box truck. The liquid, initially thought to be flammable and feared to be toxic, are neither. The substance was tested, determined to be organic in nature. The truck loaded with Soylent Green. Its people, stay tuned for updates. I'm Roger Galloway, KNRP News 10.
So basically, that was our IT department from Mojave County working with Roger Galloway. They put this, and our actual RPIO, Danny Lagana, they came up and put this scenario together, and these news briefings together. We had throughout the tabletop exercises, just kind of add some real flavor to the play of the exercise. What were our objectives in the exercise? The first one was to improve multi-agency coordination by involving all relevant agencies and stakeholders to test and evaluate the effectiveness of the Fatality Management Plan and the Family Assistance Center Plan, with the aim of identifying areas for improvement and determine if the plans activation procedures were adequate to initiate the plans as written. And this is basically testing capability 3 of public health emergency preparedness capabilities, which is emergency operation coordination. The second objective was involve the relevant agencies and stakeholders to test and evaluate the plans with the aim of identifying areas for improvement and updating the plans accordingly. Clearly identify, define, and communicate the roles and responsibilities of each participating agency in order to facilitate effective collaboration and coordination during the mass fatality incident and make changes to the plan as necessary, as well as identifying victims identification, tracking capabilities to test and evaluate the effectiveness of the Fatality Management Plan and the Family Assistance Center Plan, and the aim of identifying areas of improvement and updating the plans accordingly, and determine that there are clear roles and responsibilities assigned with overall goals and objectives for family reunification of the Family Assistance Center operations as outlined in the plan. And that was basically capability 5, which is our family fatality management. And thirdly, the third objective is to identify surge management capabilities of hospitals, EMS, medical examiner's office, vital records, family assistance, and funeral industry, and identify patient identification and tracking capabilities to test and evaluate the effectiveness of the plans and aim to identify areas for improvement and updating the plans accordingly. And this is basically capability 10, which is our medical surge. The strengths that we determined as a result of our exercise was interagency communications and cooperation, clear roles and responsibilities. We had lots of involvements from our COADs and VOADs, and people utilized the plans to answer questions which promoted conversation. One of the past issues we had with some of our tabletop exercises, people were so ingrained and knew the plans just because of prior way we had done things or responses, that they really didn't even have to look at the plan. They just said, this is what we did and this is how it works. One of the things that we're really striving for in this exercise is people to look at the plans and see if the way we do things or we think we're going to do things is the way they're actually written in the plan. So that was really important, what we were looking for. As a result of getting together after the tabletop exercise was completed, we did a hot wash, which basically is a review of what happened during the plan. From that, we then had another where we got a whole bunch of other members, key players that were part of the exercise. We met again, and we had another hot wash, basically, and we came up with some areas of improvement. One was in our family fatality management plan, we have a quick reference action sheet, and in this sheet, it basically gives you like steps. Is this, did this happen? If this happened, did this happen? Type references. And one of the things that they said, hey, we didn't have any page numbers, so they couldn't go back to the plan to maybe review some of that information to see if it fit that criteria. So we actually put page numbers into the plan on that action sheet. Possible triggers to activate the plan. We made the statements quite a little bit more clear to people that are reading it to make sure that when there's no ambiguity when they're reading it. So it's a matter of fact, so they can say, yeah, we need to activate it because of this. There's a network within the fatality management plan, which we identified a little bit clearer so people understood what that was. We reworded vital records just to make it a little bit more concise, to make sure that we only gave eligible people the records from that death certificates. We only gave those to the eligible people that can receive those. In the Family Assistance Center plan, Mojave County Emergency Response and Recovery Plan Appendix A, they have a donations and unsolicited volunteer management section. We made it more clear within the fact that that is the plan we're going to refer to if we have a situation of mass donations, because whenever there's an incident like that, you're going to have people from all over the community, as probably well over from all over the state or the nation, where stuff is going to come into play. How do we manage that? And we have that taken care of in the Appendix A of the Mojave County's plan. And then in the FACT plan, make sure mental health counseling is HIPAA compliant when setting up a FACT facility. We wanted to make sure we weren't violating anybody's HIPAA rights. So basically what we did is took all of those improvements and put them into our plan. This is just a screenshot of the plan saying that that's what we're going to do. And I'm not going to go over each one of them because I just did, and it'd be quite redundant. But it basically says what we're going to do, how we're going to do it, and who's going to be responsible for it. On these, most of these, I'm responsible for it. And except for the last one, we're going to implement into our county's training plan another exercise, and it's either going to be a full-scale exercise or a functional exercise in which we actually put these plans in action in a real-world situation, not at a tabletop setting, but actually setting up the Family Assistance Center to where we can to actually see how they work in a real-world operation. Is there any questions on that?
Yes, we have a question from Carolyn Stryker.
How many people can, or what's the capacity available in your Family Assistance Center?
When we have it, well, there's different sizes. It depends on the size of the incident. We might open up a Family Assistance Center where it's just say, for example, there's some flooding, and it affects maybe 10 homes or something like that, but it has an impact on the community. We may be able to set up this family assistance center to help these 10 families get information and get the resources they need. And then it could go all the way up to where it's an incident like this where you have hundreds of people. We should be able to accommodate that. Now that's how it's written in paper. So what we need to do is in the future is actually set it up and to see how well the plan actually operates. But we do have it set up to where we can take a pretty good sized chunk of an incident or a larger incident and provide resources to them.
Okay, thank you. Any other questions?
The Arizona Health Alert Network. I'm not sure if any of you are familiar with this. It's a mass notification system that's been around for quite a while. It's recently been updated and is a lot more user friendly. And what this application is used for is to distribute information to public health information to health officials and professionals. And it's a web-based application, and it's available 24/7, 365 days a year. And what we plan on using it for is to communicate with different entities within Mojave County. So one of the things that we've probably lacked in the past for notification purposes is notifying the Board of Health of circumstances that may be something you may need to be aware of. And what we plan on doing is putting your contact information with your approval into the system. And then when we have a situation where we need to notify you of, for example, I think it was last year we had the TB response in Bullhead City area. It was probably pretty important for you folks to be aware of that, being that it had a potential huge impact on the health of the community. What we could have done is just put out a fast message to everybody that says, hey, we're activating our emergency response team and we're going to be responding to this incident in Bullhead City. We're not going to go into detail on that, but at least it'll notify you of what's going on, and then you'll be followed up with additional information in the future. We're also going to be using it right now when we notify hospitals or emergency rooms or doctor's offices. We use what they call a blast fax, and basically we run a document through a fax machine, and it's distributed over the network through their fax system. We're in the process of contacting those organizations and getting their contact information and putting them into the system to where we can notify them not only by fax but by telephone message. We can notify them by text messaging and emails. So there'll be a lot more fluid communication process when we need to get information out in a hurry. So over the next couple of months, we're going to be reaching out. It might be from the Medical Reserve Corps folks, from them, or folks from my office are going to be reaching out to each one of you and say, hey, what contact would you like to be contacted through this system? And if so, what would be the method you would like to be contacted? So they'll be contacting you individually just to get that information so you don't have to register in the network. If you're already registered in the network, we can get that information to you and just add it to the system. Is there any questions on that?
Any questions from any board member, present or on the phone?
Just a comment on the communication is so important. I'm glad we have that system. And just for the future, do we have way for bidirectional? Right now, the text messaging and like you mentioned, the email, it's just one direction. That way, the board members, if they have question or contribution, they can, it's always good to have a bidirectional. And I know it's have to do with application and, the device and method. But if we have that available, that would be great.
At this point, I think it's just one direction. One of the things that we can do in a message, though, is if you contact this person if you have any questions or whatever. So we can put that right into the text message.
Right.
Or the email. And that would probably be, text messages are really small, so it's going to be mostly refer to the email for further details. But usually there's contact information in those emails to.
Or we can have,
provide that.
when situation happen, we can refer to a messaging group. That way we can share more insight.
That would be something we'd have to explore, because like I said, this system is a state system that we're kind of piggybacking off of, but that's probably something that we could kind of consider, yes.
Something to think about, yeah.
Okay, well, thank you very much for your presentation. I know when these kind of events come up, it's always nice to have kind of played with the idea and the what ifs. So I certainly, with my background, appreciate the practice.
Thank you.
Okay, next on our agenda, we'll have the Public Health Suicide Mortality Report Annual Review by Jessica Willard. Jessica is the Community Health Education Specialist, Behavioral Health and Epidemiology.
Good morning, Madam Chair, members of the board. Thank you for having me today.
That's a really big title.
What's that?
That's a big title.
Yes, it is quite a mouthful, especially since I am in multiple programs. So let's go ahead and open this. Okay. So like she said, my name is Jessica. I do the suicide mortality review for all of Mojave County. Our mission is to promote, protect, and improve the health of our communities, and we want healthy people in healthy communities. So just a little bit of background on SMR. In 2020, Arizona legislature passed the SB 1523, otherwise known as Jake's Law, with unanimous support. It was named after an individual who sadly took his own life. His name was Jake Makovsky. I believe that's how you pronounce it. And his parents, Denise and Ben, started the GEM Foundation in an effort to end youth suicide and expand behavioral health services, kind of keep insurance companies accountable and things like that here in Arizona. Out of that was also established the Suicide Mortality Review Team, in accordance with ARS 36-199. And then the Mojave County Department of Public Health has responsibilities for protecting that in accordance with ARS 36-132A, and also in accordance with ARS 36-199.01. And it just grants us the authority to kind of investigate all of these deaths. So the goals of our program, it seems like a lot, but it's pretty straightforward. We want to identify the barriers and the service system issues experienced in the suicide deaths. We want to identify the risk factors and trends in suicides, potential protective factors that may decrease suicide risk. We want to improve the delivery of services to individuals, families, and community members. We want to analyze the adequacy of state and local laws, trainings, and services to recommend that changes are needed to decrease the occurrences of preventable suicides, and as appropriate, take steps to implement the changes. We also want to inform local and state suicide prevention strategies and educate the public regarding the incidences and causes of suicide, as well as the public's role in preventing the suicide deaths. So here's just a couple of statistics from 2019 and 2021. In 2019, suicide was the 8th leading cause of death in Arizona, 10th leading cause of death in 2021. There are about 1,400 deaths in each year, and the suicide rate per 100,000 is about 20%. Interestingly enough, also in 2022, there were 1,596 suicide deaths in Arizona. There were 114 in Mojave County, and we'll talk about that a little bit later, but our suicide fatality rate that year was 21.5 per 100,000. Mojave County is also the 5th highest county for suicide deaths in the state of Arizona. We are followed only by Navajo County, who's 37. We have a 36 per 100,000 average rate of suicide death here in Mojave County. Navajo is 37, Apache is 41, Gia is 42, and La Paz is 45. So these are just a couple of the types of records that we look for when we do the suicide mortality reviews. These ones that are highlighted are where we get the majority of our information from. So whether or not they go on the suicide mortality review is based on their death certificate and how the death is pronounced on the death certificate. So if it's listed as a suicide, it gets put on my list and it comes to the review. The medical examiner reports and the investigations that they do during those periods of time after the bodies are found. Hospital nursing and medical records are also a huge factor in determining if the individual had pre-existing conditions. We also ask for mental health records, but we don't get those quite as often because not all of the individuals on our review have sought mental health services at any point. And then law enforcement reports are also very, very important. So the two main ones are really the law enforcement reports and the medical examiner reports. That's where most of our information comes from. For a lot of our individuals, sometimes that's all that we get. And then those others are just a couple of the other places that we seek information from, but we unfortunately don't always get it. So this is just a list of our program procedures. So like I said, the cases are assigned based on the decedent, how they're listed on the death certificate, and then their physical address. So even if the decedent passed away in a different county, if their physical address was on an identification that was found is listed as Mojave County, they are put on our review board. Typically, the last couple of years that I've done this review, we have about 5 or so individuals who pass away in other counties, but the majority of individuals actually pass away here. So everything is confidential. So any requests or receipts for information, presentations of records, documents, or any other information, and then any discussions regarding cases or any information entered into the data collection tool that we send to ADHS. We're also not subject to subpoena, discovery, or introduction into any civil or criminal proceedings. The meetings and individuals who died are not subject to open meeting laws. So for anybody that's not familiar with those, Arizona has what they call open meeting laws, which mean that the public has access to certain types of meetings and certain types of information. The suicide mortality review is not a part of that. And then any and all persons who may have access to information or records are required to sign a confidentiality agreement annually, and those are kept within Mojave County Department of Public Health's possession for the request of ADHS at any time. And then also, it is a Class 2 misdemeanor to violate any of these program procedures, especially any of the confidentiality agreements. So a couple of things we do not review for. So kind of like Selena had mentioned in her presentation, there are other review boards for suicides for persons younger than 18 years of age. And then women that were pregnant at the time of death, that's the maternal fatality review that's done by ADHS. And then undetermined or accidental deaths. Like I said, it has to be listed as a suicide on their death certificate in order for it to come to our review board. We already mentioned that. So just a little bit about our meetings. We share, question, and clarify all of the case details. We discuss the investigations that happen and any notes that we were able to obtain. It is absolutely not meant to place blame on individuals or agencies at any point. So, for example, if an individual is seeking mental health care services at a certain place and they did decide to take their own life, in these meetings we're not trying to say like, oh, that's your fault because they were seeking your services and you didn't do enough or anything like that. That's not allowed in our meetings. We do discuss the delivery of services, identify risks and protective factors like I talked about. And then our biggest thing is we recommend systems improvement and identify and take action to implement the prevention recommendations. So here's a list of the prevention recommendations that we go over. We have a couple of different categories, and one of them is healthcare. So in this category, we have improve access to appropriate mental health care services, improve ED and inpatient hospital discharge practices by establishing follow-up protocols and case management for those who have come in for a suicide attempt or suicidal ideation. Increased training for healthcare staff to better treat and screen for depression. So this one's kind of a big one because a lot of the individuals who end up on our list actually did seek healthcare within the last 365 days. Then they want to increase community awareness and support organizations to assist during immediate crisis and into recovery, implement best practices for prevention and healthcare systems, and then increase access to remote mental health management resources. This is our criminal justice section. So our choices are to improve access to appropriate mental health care services, access to SUD orders and MAT treatments during incarceration, and then care coordination post-release, so those warm handoffs to those other services, access to social support resources post-release, and then the training for evidence-based suicide and self-harm prevention for the corrections, health, and custody staff, which my program's actually trying to do right now, working with the GEO group out at the prison. Then crisis response, so we want to increase access to appropriate mental health and substance use services, increase training, and then the number of crisis response teams. And then community, so this is kind of our biggest section, and I'll go in depth into that in just a minute, but this is the section we identify the needs in the most. So we want to improve access to social support resources, housing, employment, insurance, transportation, support for individuals with past childhood trauma or ACEs, like domestic violence, assault, loss of a loved one, and then improve social connectedness, so relationships with neighbors and friends, coworkers, things like that. They also want to decrease the stigma and increase help-seeking behavior. So a lot of individuals that come to our list, we've noticed that they don't seek any kind of mental health care services, at least not from the investigations that we can see. And then we want to improve access to the suicide loss and attempt survivors. Number 6, reduce access to lethal means by those who are at acute risk of suicide. So those who have either had suicidal ideations or attempts in the past. And then increase gatekeeper training, so enable people to identify those risk factors and how to help individuals who have those suicidal ideations. And then education and awareness for the population-based mental health and wellness. So, sorry, this is kind of small, but these were our demographics for 2022. So almost 20% of our cases were veterans here in Mojave County. The biggest ages that we saw for suicide were 75 to 84, and then the 25 to 34 and 35 to 44 age groups. Overwhelmingly, about 85% of the cases for suicide are males, and then about 14% are female. So this is the means by which individuals have chosen to take their lives based on the medical examiner report or the law enforcement reports. Over half, so 60% of those are firearms. About a quarter, so 22% are hanging and strangulation. 12% is poisoning by drugs, so that is individuals that would purposely take their own lives by overdosing. And then other means, so those can be jumping, exsanguination, things like that. So like I mentioned, in 2022, there were 114 suicide-related deaths in Mojave County. I reviewed every single one of those cases, and it was a lot. We had 7 meetings between August 2023 and June 2024, and the average attendance in person and via Teams was about 15. So our top recommendations, healthcare, was to increase the training for healthcare staff to better screen and treat for depression. The criminal justice was to increase the training in evidence-based suicide self-harm prevention for corrections, health, and custody staff, which is why that was one of the aims of the program that we're in here at Mojave County. Crisis response was to increase access to appropriate mental health substance use services. And then, like I said, community was the biggest group. So we have 3 down there that were the most recommended. So increasing the gatekeeper training, reducing access to lethal means, and decreasing the stigma and increasing help-seeking behavior. So I apologize again, this is kind of small, but I wasn't sure how else to fit it on a slide. But this is just a breakdown of every meeting that we had and how many were recommended in each group. So you can see kind of down there towards the bottom, the reducing access to lethal means. We had 70 votes for that specific measure as a reduction of suicide risk. And then the same thing with the increasing gatekeeper training. More often than not, these individuals have either had suicidal ideation in the past, or there was somebody around them or close to them that knew that they had a history of depression or anxiety, or they had talked to about their plans to take their own lives. And then we also up here, I'm sorry, it's kind of hard to see, but we have the decreasing stigma and increasing help-seeking behavior. A lot of individuals we see don't seek any kind of mental health services. So in addition to the recommendations that are set forth by ADHS, we also have the ability to kind of come together as a group and decide for additional recommendations. So firearm safety for those who are diagnosed newly or otherwise with dementia and Alzheimer's, which that kind of stemmed from the age group that we saw and the amount of individuals that took their own lives after they had been diagnosed with something like that. Terminal illness support. So again, we did see a large number of individuals who had a terminal illness or who were kind of going towards end of life care. The locking up or securing of potential objects for individuals with previous attempts. And then increasing resources available at hotels and motels. This one was from our lovely Director Melissa Palmer. For those who are contemplating suicide. So providing those materials in hotels and motels because there are a significant portion of individuals who take their lives in those locations. So this is just for our next year's program outlook. Currently, we're reviewing 89 cases for our 2023 case set. We talked to people from all different areas of the community, so first responders, healthcare professionals, crisis teams, faith community, school district, justice groups, and then groups serving high-risk populations. We have a really good group that serves on our board right now. And then that was everything. Were there any questions? Sorry, I know that's like, it's a lot.
Thank you very much. Any questions from the board members? I guess your presentation was very thorough and effective because we have no questions for you, but we do appreciate the information, and it'd be nice not to have this report or the need for it in the future.
Yeah, we're in the business to go out of business is what I always say. So
There you
thank
go.
you very much.
Very well put. So going on now to the official business to come before the board, and I think our first item of business would be to introduce our new board member, Caroline Stryker. So if you want to say a few words, maybe tell us how you became interested on our board or your expertise, the floor is yours.
Thank you, Chairwoman Bishop. So hello, everybody. So my name is Caroline Strecker. I've been in Mojave County for almost 20 years. I went to the MCC nursing program. I teach now in the program. I am a nurse practitioner. I started out at KRMC. I've worked at Needles. I've worked at Valley View. I've worked at Warmc. I did CareFlight for some time. And then I was at Georgetown's nurse practitioner program, but their tuition was very expensive. So then I decided to go to Maryville University, where I graduated and got my family nurse practitioner. And how I came to the board, originally I was on the Public Lands and Recreation Committee as appointed by Supervisor Gould. And then he actually had asked me had appointed me and asked me if I would come join the Board of Health. So that's how I came to this position.
Well, thank you very much. It sounds like with your background, this is a perfect committee for you to sit on, and we appreciate you being here. Okay, I'll entertain a motion at this time to approve the Board of Health minutes for April 22nd and July 22nd, 2024.
So moved.
Madam Chair?
Yes, go ahead.
This
Who
is
is that
Sandra
on the-
Thomas. I was just gonna make the motion to accept the April 22nd and July 22nd, 2024 Board of Health meeting minutes.
Okay, we
Second.
have a motion. Would you like to amend that to a second instead?
Yes, sure.
Okay, thank you very much. We have a motion by Byron Stewart and a second. All those in favor say aye.
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 Is there anyone opposed? Okay, the minutes are approved. Next, we'll go on to the regular agenda. This will be a discussion of possible action to review the routine summary of select reportable diseases in Mojave County from January 1st, 2024 to September 30th, 2024. Miss Anna, good morning.
Good morning.
That's a very brief report.
Yeah, it sure is. I don't think it made its way onto the screen here. But I believe that you guys have it as a handout, and luckily there's not a whole lot to discuss. It's really exciting here. But covering Q3 for calendar year 2024, we've had basically what we more or less expect, and not a whole lot outside of that realm. The case counts are a little bit lower for Campylobacteriosis, and that's just the way it is. I don't think there's any way to explain that one way or another, except that we're just having a good year, maybe. Some of the other types of illness, like carbapenem-resistant Enterobacteriaceae infections, those are going up. That's a type of antibiotic-resistant organism that might be found in wounds. But we've expected that all along. That was added to the reportables list a few years ago. And so we started from nothing, and we expected that it would grow and grow and grow over time. So those numbers have gone up a little bit. And of course, we always like to talk about cocci and valley fever. And we have mentioned over 2024 that some of the numbers at the state level and also our level have been unusually high. And they were high enough that the state health department looked into it a little bit closer, and lo and behold, they did discover a slight problem with one of the commercial laboratories. And so they had been testing more folks than usual, and there was a problem with one of their particular test kits, so that there was a higher likelihood of the test coming up positive. So there does seem to be a bit of an artificial increase in the case count numbers. But what's interesting for Mojave County is that the proportion of our case reports isn't terribly high for that particular laboratory. So I think we really do just have more cocci cases, more valley fever cases this year than we have had in the past. How significant it is, I don't know, but we'll keep an eye on that. RSV, you see we have larger numbers of respiratory syncytial virus. Those are all the old cases from last spring. So nothing new has jumped in. We opened the new respiratory illness season October 1st, or the first week in October. I can't remember what the date was, but we haven't seen a great, big, huge increase in anything yet, but we'll see what happens as the months progress. Generally in Mojave County, we tend to see the highest number of respiratory illness, so COVID, influenza, and RSV during the holiday season. So at some point, maybe it'll start clicking up, and then we'll get more and more cases as things go through, or maybe it'll just be a different year, and that won't be the pattern that we see this year. Salmonellosis cases, we have fewer than last year, but somewhere around what we expect for the 5-year median. And I will mention that 3 of them were linked to bigger outbreaks. 2 cases of Salmonella enteritidis were linked to a barbecue family gathering that didn't even happen in our state. It happened elsewhere in the United States, and that state and that local jurisdiction had done the investigation for that outbreak. So they were residents of Mojave County, but the illness had nothing to do with Mojave County. And then there was one case of Salmonella abundanca that was linked to backyard flocks. So I'd like to point that out because I know the chicken flocks and the home chicken flocks and the backyard flocks was a big topic for quite some time in the past couple of years in certain jurisdictions. And every now and then we do have cases of Salmonella that can be definitively linked to backyard flocks. And in terms of a backyard flock, I'm not saying that one flock somebody who's keeping chickens here in Mojave County is causing problems. More likely, a chicken was sourced from a place that had a problem. So the place where they got their chicken from. And then the chicken comes with the infection and then perhaps jumps into a family member or something. And the last time I addressed you was actually in April. I didn't get to address you at the last meeting. And back in the springtime, one of you guys asked for a little review of something that had hit the news. So last March/April, there were a few little news releases about canine schistosomiasis and caused by Heterobilharzia americana. And so this is happening in dogs. And since 2018, in Southern California, in 3 different counties, in Orange County, in LA County, and Riverside County, there were about 11 dogs, family dogs, from 5 different households. So sometimes it was more than one dog in a household. But there were about 11 cases of canine schistosomiasis that were presenting to veterinarians in Southern California, not here in Arizona. And every last one of them reported that the dogs had been spending some time swimming in the Colorado River, actually near Blythe, so right on the border of Arizona and California. And the veterinarians were astute enough to go and look into some testing, and they tested for this particular parasite. And the point to this, and why it made the news, is because this parasite had not been known to be endemic or just plain outright was not previously found in the Colorado River. It was found in the Gulf states, so areas east side of Texas, Florida, Georgia, actually all the way up into the Carolinas. They'd had cases, Louisiana. That's generally where most of the cases, the canine schistosomiasis, were being identified. So the fact that all of a sudden we had these dogs over here in Southern California, it didn't make sense. But as soon as that connection was made, and that's the way epidemiology works, when you hear a story like that and everything's kind of coming together just like that, University of California, Riverside has a lot of experts in toxins and zoology and parasites and that type of thing. They jumped on it. They went to the river, some river sites near Blythe, and sure enough, not only did they find the parasite, but they also found the snails that are part of the life cycle for that parasite. So this is a complex parasite. It's not a bacteria, it's not a virus, nothing like that. It's still microscopic, but it's bigger than those types of things. And it has what's called a complex life cycle. And that is because it requires 2 different living organisms to complete its whole life cycle. If you were to break either one of those organisms out of the life cycle, you would lose the parasite there. And in the case of this organism and this parasite, it's snails in the Colorado River. And then what brought this to attention was that it was showing up in dogs. Obviously, dogs are not necessarily part of a life cycle in a wild land, but you can find it in raccoons or coyotes or deer or the wildlife that would be using the water. And more or less what happens is if there's eggs in the water, they can form into a stage known as a Maricidia. And the Maricidia are found in the water, and they can penetrate into snails. And once they're in the snails, they can mature to some level to another state that's called the Cercaria. And the Cercaria are released out of the snails that are there in the water. They're aquatic snails. And if you happen to have one of those mammals, in this case maybe a dog, in the water when those Cercaria are released, those Cercaria are actually free swimming, and they can burrow through the skin of one of these mammals or a dog. And then once they're inside the dog, they tend to travel to the lungs or the liver of the dog, where they mature into adults. And then they tend to travel in a dog to certain veins, especially the mesenteric veins in the abdomen and associated with the intestines. And there they live quite happily. They reproduce, they produce more eggs. And lo and behold, these eggs that are released inside the body of the dog have the ability to burrow through the intestinal walls into the lumen or the opening of the intestines where the feces are made. And when the dog defecates, if it happens to be near that water source, or if it's a wildlife, if it happens to be near that water source, lo and behold, you've just introduced more eggs into that system. And the eggs change into the Myristidia, they infect the snails, and the cycle goes continuously like that. So the big news, and the reason why that was in the news, is because it had not been identified in this area previously, but it's certainly there because we've had these dogs since 2018, numerous cases, found the snails and the parasites, so there's no question that it's there. There's been no reports up this way necessarily, and I'm no expert in snails. I assume that we have the ability to have those snail populations here. I don't know for sure, but I would guess it could be something up here. And this life cycle is very, very, very similar to the life cycle that we've talked about with swimmer's itch. And actually, I believe that this particular parasite, the Heterobilharziia americanus, can actually cause swimmer's itch in people. The key with people is that once it burrows into our skin, that's it. It can't move through our body. It cannot grow into adulthood, cannot produce eggs. It burrows into our skin and dies off and makes you itch like crazy because you end up with an allergic reaction. So the problem with the dogs, it can be asymptomatic in dogs, but under certain conditions, those eggs don't make their way through the intestinal wall and they just end up in the intestinal wall. Or they're carried to other parts of the body like the lungs again, or the pancreas, or the spleen, or the lymph nodes. And that's not where they want to be. And maybe the dog's body starts to recognize that those things aren't supposed to be there and kind of starts to encapsulate them. And you end up with these little granulomas where the immune system kind of closes off and walls off these, little conglomerations of eggs. And you can imagine that it would not be good for your pancreas to be full of little granulomas. Eventually, you can end up with big problems depending where those granulomas are in the dog. And it can also kick in overall inflammation in the dog. So the symptoms in a dog are just they're insidious, just kind of a slow onset, and just over a period of time, you might notice that the dog has a lot of extra diarrhea, maybe bloody diarrhea. It's lethargic, appetite's not good. And the key with all of this, since it's here, it's new, it's newly seen, is to get the veterinarians to consider it on their differential diagnoses and let people know that, yeah, it is out there, so we should consider it. There are some treatments for dogs, although it's not really determined, but there are some drugs that they can use to treat the dogs, and sometimes it's quite successful. It can be fatal in a dog if you have the granulomas in the wrong places, under the wrong situations, and they don't respond right to the treatment. But that's what I had to say about the canine schistosomiasis.
Anna, if I could ask you, can a dog that's been infected with this this disease passing on to another dog? Not necessarily both in the same waters, but...
No, you have to have that snail intermediary host because the eggs don't infect dogs. Dogs will release the eggs, but the eggs only infect the snails. And you have to have the particular snails.
Okay, is there any treatment for the waters to eliminate the source?
Not for a wild waterway. There's nothing that could, so technically speaking, sure, but realistically, no.
Is there any visual indicator that these might be present in a water, say something visual floating on the water?
No, there's not. In terms of human swimmer's itch, so same similar cycle with the people, we don't know what causes the release from the snails. Why does it come out of the snails? And with the swimmer's itch that I've looked at with people, there tend to be mass releases. So there's some reason that those cercaria come out in large amounts from the snails. Could have to do with the sun level, so sunrise or sunset or something like that. Could have to do with the temperature in the water. Could have to do with something that we just simply don't know. And I have heard people suggest that the water looked a little cloudy, but I don't know that there's any truth to that. Those are people who ended up with swimmer's itch describing what they saw, and I don't know at all if there's any truth to it. These are microscopic little things. It's amazing that they found the parasite itself in the water. You can find the snail, certainly. The parasites themselves are a little more difficult.
Okay, and your advice to people who take their dogs to the lake? Keep them on a leash and out of the water.
The biggest thing, the biggest consideration is if your dog is showing symptoms, the key is that if the veterinarian can think to look for it, then they can look for it. There's tests that they can do. They can do PCR tests to see if it's there. They can do imaging to see if, the dog is full of those granulomas. There's tests that can be done. So half the battle is just knowing what you're looking for.
And no vaccine available?
No.
Okay. No. Any of the board members have additional questions?
Just a quick question on the snail. Is this a native for the local or no?
Great question. Maybe the whole reason this is new here is because the snail has been carried by boats or something,
Right.
and it's actually a new place for the snails.
Right.
And that's what kicked off the whole
Exactly.
problem.
So
And I have no proof one way or another. With human swimmer's itch in our area, we had never heard of it. And then all of a sudden it shows up. And I have no proof of this. It just feels like maybe those snails started to
Right.
show up in our area.
So do we have any way to question is, can we eliminate the snail, or do we know which area have more snail than other snail so we can let the public aware?
So the snails tend to be along the edges. They don't like the flowing water. So with people in swimmer's itch, and the same would be for a dog, if you're on the boat in your middle of the lake or the middle of the river, it's not going to be a problem. It's along snails like the stagnant water, the reeds and all the debris in the water along the edges. So that's where the situation would be worse. We could not, since it's a federal waterway, you couldn't do anything with the Colorado River waters to remove the snails or species or anything like that. And I'm just guessing that there might be more than one species of snail that can carry it. So once it's there in the water, there's going to be enough of a cycle.
Thank you very much, Anna.
Thank you.
Next, item number 3, this will be a discussion on possible action, evaluate and recommend to the Board of Supervisors funding for a public health nurse practitioner, a grant-funded position, and authorize the recruitment and hiring of a regular part-time family planning program practitioner.
Good morning.
So that sounds difficult to get a nurse practitioner on a part-time basis, but
It has been, yes. And this agenda item is specifically seeking approval to reclassify our nurse practitioner position, which has been vacant for over a year now, specifically for our family planning program. Right now it's classified and we're recruiting it under a temporary paraprofessional position, so a temp position, and we'd like to have it reclassified to a regular part-time position with the hope that the regular part-time position, it offers more benefits than what the temporary position does, such as paid time off accrual and some paid holidays. So that's our whole goal, is to get it reclassified, make it more enticing to qualified applicants.
understand. And it's grant-funded, I understand.
It's 100% grant funded, yes.
Okay. I'll entertain a motion to approve.
I second.
Okay, I'll make that a motion, and it was seconded. So all those in favor say aye.
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 Anyone opposed? Unanimous support?
Thank you.
Motion passes. Next item, number 4. This is a presentation on public health concerns, health-related issues that may or may not occur with the power plant near residential neighborhoods, and possible discussion and action by the board. And I just want to say that I think that the timing of this presentation on the eve of the Board of Supervisors vote could be seen as an attempt to influence a Board of Supervisor decision. So I want to remind this board that public health does not have the resources to do a factual analysis, and what's been provided on the proposed PowerPoint is information reference to national standards like the CDC, and we know how that went with COVID. We don't really trust the CDC in Mojave County. So our Board of Health deals with factual information. So I'm going to continue this item until we have time to get more specific information to Mojave County and make sure that all the stakeholders have been notified. So with that, this will be continued to the next board meeting, and we'll go on to item number 5.
Madam Chair, so I think this, as long as we have 3 business days to the public, this should not be violate the public meeting laws. But if you would like to continue, we need a quorum to make it happen.
We need a motion to continue it?
Yes.
Are you sure? Well, you're our attorney, I guess you're sure. Okay, I'll entertain a motion to continue.
Madam Chair, I'll make a motion to continue this item.
Okay, thank you. Do I have a second?
Coyle, second.
Thank you. We have a motion and a second. All those in favor say aye.
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 Anyone opposed?
Nay.
We have 1 opposed. The motion passes to continue.
Sorry, forgot to mention, what date and time are we going to continue to next meeting?
The next meeting.
Okay, thank you.
Item number 5, this is a discussion of possible action to review and approve the Mojave County Board of Health bylaws. Okay, Melissa, I guess this is yours.
Yes, we sent out this is continued from the July meeting. I sent out the Board of Health bylaws, and there was only one item that we looked at correcting, which was actually adding a comma under motions, resolutions, and regulations under item 6. At the July meeting, it was discussed about the naming of the chair and vice chair. Instead of using the word president, using the word chair. And then with some guidance from our attorney, it was stated that since the ARS names them as president and vice president, that we would keep president and vice president in our bylaws. So if everyone has reviewed it and are comfortable with the way they are, I would like a motion, though, for that.
Okay, any comments or questions? If not, I'll entertain a motion to approve.
Second.
I need a motion first.
Oh.
Okay. We do have a
Second.
motion and a second. All those in favor say aye.
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 Anyone opposed? Okay, motion passes. Thank you. Next, item number 6, discussion of possible action, elect a board health president and vice president per Mojave County Board of Health bylaws, Article 2. This was continued from the July 22nd meeting. So I'll entertain any nominations for the Board of Health president. Nobody wants to be president. I am retiring. I cannot go on.
As a reminder to everyone, Supervisor Bishop is our president, and then Mayor Sheehy is our vice president, who could not attend the meeting today. However, with Supervisor Bishop's retirement, we will need a president.
Well, since Mr. Shealy is not president, maybe we should nominate him as president.
I second that nomination.
I didn't hear that. Could you repeat? So anybody want to volunteer to be president for this coming year? Okay, we have Hunter Adams, Terry Coyle, Robert Litz. He did indicate that he would be willing to serve. Byron Stewart, Carolyn Strecker, although she's very new. Does it have to be one of those as president, Melissa?
It needs to be whoever's on the board currently. It can't be myself or the clerk or.
Okay, well, we're going to be here all afternoon until we get a nomination in a second.
Is Robert Litz still interested in it? He had talked about it.
I believe he's on the phone. Mr. Litz, are you still willing to serve as our president?
You are muted.
Your mic's off.
Mr. Litz, you're muted.
Is that working now?
Yes, it is. Thank you.
Yes.
Okay, yeah. Well, my name is Robert, but I'm not practiced on Robert's rules of orders here lately. But if you want to nominate me, I guess I will accept that and get to work on it. So.
Okay, thank you. So Byron, was that a nomination?
I nominate Robert Litz for president for next year.
Very good.
Second.
Any other nominations for president? Any other nominations for president? Hearing none, we have a motion for Robert Litz to be our new president for the upcoming year, and we have a second. All those in favor say aye.
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 Anyone opposed? Congratulations, Mr. Litz, or President Litz. Now we need a vice chair or vice president. Any nominations for vice president?
I'll be interested in that position since this will be my first year completed.
Okay, and was that Coyle? Okay,
This is Coyle.
thank you very much. I appreciate that. I'll make that in the form of a nomination for Mr. Coyle. Do I have a second?
Second.
Okay, any other nominations? Any other nomination for vice president? Last call. Okay, we have a motion to appoint Terry Coyle as our vice president. We have a second. All those in favor say aye.
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 Anyone opposed? Very good. Congratulations, gentlemen, and thank you for stepping up.
Madam Chair?
Yes, go ahead.
I would just say now we've got two rookies going to run the show here next year. So good luck to you, Terry.
You'll have plenty of help. I guarantee you. You'll get the support to make you shine.
I'm confident of that.
Thank you. Going on to item number 6, discussion of possible action. Oh, wait, we just did that one.
Yes.
We don't want to do that one again. That's it? I'll entertain a motion to adjourn.
Excuse me? This is Coyle.
Yes.
I had one more thing on my agenda docket. It was the South Point Energy Center.
That's been continued. Or the South
Okay.
Point.
Earlier.
I don't have that on my agenda.
Nope.
We had item number 4 on a power plant presentation. That was continued.
Okay, I have the one regarding back taxes collected, although the property was on Indian land.
No, that may be on the Board of Supervisors agenda.
Yeah.
Huh, I wonder why this is in my packet.
Does anyone else have that in their packet?
Madam President, this is Sandra Thomas, although that, my comment is not in response to Terry's. I just wanted to thank Jean Bishop for her service on the board. And as board president, she is an amazing woman and such a benefit for Mojave County. Thank you. It has been a pleasure to serve with you.
Thank you so much. I appreciate you saying that, and especially since I'm retiring and you don't really need to. Thank you, Sandra. Okay, this meeting's adjourned.
Thank you very much.